Do you want me to start?
So, good evening and welcome to the monthly CPD program of the Ceylon College of Family Physicians. I would like to welcome and thank Dr. Kishara Goonerathne for kindly agreeing to be the resource person for this month's CPD. He's a neurologist and a senior lecturer attached to Faculty of Medicine, University of Moratuwa. And he has a special interest in movement disorders. So that's why we wanted him to talk to our audience regarding the movement disorders. So over to you, Kishara. Kishara, you're muted.
Sorry. Can you all hear me?
Yes, very well.
Right. Okay. Thanks. Someone asked me. Right. Okay. Right. Okay. Let's start. Okay. Okay. So thank you very much for the invitation by the college. Want to thank both the college as well as my good friend Priyanta, who I could not say no to. So, let's talk a little bit about movement disorders for primary care physicians. Right. So, I like people to interact with me. Otherwise, I generally fall asleep. And that has also happened many times while doing very online talks. So if there's anything that you want to ask, you can stop me and ask. Or if I have a few questions to ask you, that makes it much more interesting. You can always interact. Okay, so why do you think it's relevant to know a little bit about? Sorry, this doesn't seem to go away.
You can stop share and share again. Share.
Yeah, no, I just stopped. Oh, why? Yeah, hang on. Just give me a second. Okay. So, why is it relevant to primary care? One is that you must all know that Sri Lanka is now an aging population, and it's not really limited to Sri Lanka, it's worldwide over. Most communities, especially in the West, uh, there is basically a shift towards the aging population, and therefore these movement disorders are generally common in the old age group, which is about 65 and above. So there is increasing prevalence. That's one reason why primary care physicians need to know a little bit about movement disorders. Then, of course, movement disorders have an impact on the quality of life, and we need to identify these disorders early so that we can plan for management and long-term care. And of course, the primary care physicians, in that sense, has a pivotal role to play, especially in early identification and also when it comes to follow-up. So that's why knowing a little bit about movement disorders is important, right? So that's the relevance, right? Now, generally, we are taught about when assessing patients, we talk a little bit about history and then examination and so on and so forth. And that we have been used to that kind of approach for almost everything from undergraduate days to now postgraduate days, right? So, however, when it comes to assessing movement disorders, we talk a little bit about what we call phenomenology, right? So first we look at the phenomenology. Does anyone know what phenomenology means? What is the word phenomenology? What does that mean? There are 159 participants. Shall I pick on one? Then I would generally, when that happens, the participant rate starts dropping. Right? So it would be nice to, if someone can say something. So what do you what does one mean by the word phenomenology?
Character of the movement disorder.
Yeah. Okay. Good. So one is that. Okay. Anything else? A very simple thing. I'm sorry. Yeah. A simple term that you would use.
Kind of experience.
Experience. Okay. There are some chatbots around. Yeah, chatbots. What is the chatbox? Right. Anyway, right. Okay. So it means what does it mean? Phenomenology is in movement disorders refers to a detailed description, right? So basically, it's important to describe what it looks like, right? And then classify, right? And analyze what is observable as an abnormal move, right? And it is the cornerstone of clinical neurology and movement disorders, especially focusing on type, pattern, characters, and timing of the abnormal moves. We'll talk a bit about that in a little while. So, especially when it comes to neurology, and especially when it comes to someone actually suggested trying to explain what we see. Absolutely, that's absolutely correct. So here it's a visual art where we look and uh, try to explain what we see, classify, and then probably analyze. Right. So that's what it means. So phenomenology is very important, right? So basically, movement disorders are divided into several sort of character based on whether the movements are excessive, reduced, or whether there is impaired control, right? Broadly, they are categorized into hypokinetic disorders, where there is paucity or absence of movements, as well, or hyperkinetic, where there is an excess of movements. Now, for the quintessential example for hypokinetic disorders is Parkinsonism or Parkinson disease or atypical Parkinson. So there is a spectrum of Parkinsonism, right? So we'll talk more on Parkinson and Parkinson-related disorders throughout the talk, because that is the most prevalent of movement disorders, and it's probably one of the most common type of movement disorders that primary care physician would generally still encountered by this primary care physician are the hyperkinetic disorders, or the disorders that present with excessive movements. And then you've got some examples that on the slide: tremor, chorea, dystonia, myoclonus, and tics are some of the examples that can present as hyperkinetic disorders, right? Okay, so very simple, right? So movement disorders are generally classified into either voluntary, so they're voluntary movement disorders, as well, and involuntary, and out of which I will not talk a lot on voluntary movement disorders. We'll talk about the involuntary ones. And these again are generally divided into hypo and hyperkinetic disorders, as well as ataxia, right? So these are these are very broad classification and a very simple one. And generally, my suggestion is, once you analyze your phenomenology, it would be good to classify into one of these three groups. Okay, so a very simple classification, which I think is easy to remember. Right. Okay. So then that's the classification. So as I said, hypokinetic movement disorders, the example that we would generally talk about is Parkinson's or bradykinesia, where the primary or the main feature, which is called bradykinesia or echinacea, right? So little bit about Parkinson disease, which was described by James Parkinson as what was it described as? More than 100 years ago, it was described as the shaking palsy, right? So it's a neurodegenerative disorder, right? And generally, is caused by depletion of dopamine within the substantia nigra, right? Where is the substantia nigra by any chance? Does anyone know? Which part of the brain does that? Do you think it would be in? Yeah. Yes. Not on the chat box. Fortunately, yeah. Okay. So, yeah.
There's one basal ganglia.
Ganglia.
Sorry. Lot of.
Chat box messages as they're saying basal ganglia.
Okay. Basal ganglia. Oh, okay. It's part of the basal ganglia, but yeah, it's generally found in the midbrain. So why is it called nigra? Because it's when it's actually black. Okay, and when you do a pathology, when you cut open the brain and look at the sections of the brain in patients with Parkinson, because of the degeneration of these dopaminergic cells, they are not as black as you would generally see in a normal individual, right? Right. So there's loss of dopaminergic neurons, especially in the basal ganglia. Yeah, and there's also something called there's aggregation of these proteins called alpha-synuclein, right? Uh, and this excess of deposition of these proteins called alpha-synuclein results in this neurodegenerative disorder, right? So and this deposition generally is not only in and around the basal ganglia. It involves as the disease progresses, it involves other parts of the brain as well, and that is why it's called a neurodegenerative disorder, because due to the deposition of these abnormal proteins, or these are also called Lewy bodies. Has anyone does anyone recall a type of dementia with Lewy bodies? So it's the same pathology, right? But depends on which part of the brain the proteins get deposited, right? So if they start depositing within the basal ganglia, you see the movement disorder first. But when it starts depositing in other parts of the brain, especially the occipital part of the brain, and then as it spreads, then they do get what's called a Lewy body dementia, right? So it's a dementia. So Parkinson disease starts off with a movement disorder, ends with a dementia. So that's how the progression goes about. I hope that's clear, right? So what are the clinical features in Parkinson disease? That's important thing. Can someone tell me a little bit about what diagnostic criteria you would use? Yes.
DDT, bradykinesia.
Yeah. Okay. What?
Shuffling
Okay. Yeah.
gait.
Gait disturbances. Yeah. Rigidity. Postural
It's a
abnormalities.
postural abnormalities.
All right. Okay. Excellent. So, sorry. Yeah. So you need to observe the patient, and if the cardinal symptom and signs are all of bradykinesia, right, then that's the primary clinical feature that you would look for in patients with Parkinson's, right? So, um, uh, and then you look for other features to support your diagnosis. And as most of you all said, it is sorry. Hello. Yeah.
Go ahead, Kishara. That's probably a mistake.
Yeah. Yeah. Sorry, I'll go back again. Yeah. So I'm not trying hard to put this together. Right. So tremor. The tremor at rest is Parkinson disease until proven otherwise. So if you see a tremor which is prominently seen at rest, right, and that involves uh, the distal parts of the limbs, right? So, for example, the hands, the legs, the lips, as well as the jaw and the tongue, more likely dealing with the Parkinson disease or Parkinson-related disorder. So, if you see this, you're more likely dealing with Parkinson or Parkinson-related disorder. Bradykinesia, as I said, is the central clinical feature that you would look for in Parkinson's disease. And so of patients then generally don't come and say, I'm slow, right? Often these patients would generally present to the primary care physician saying that, I feel weak, my coordination is not so good, I feel so tired, right? Those are all feature or clinical features or clinical symptoms that might suggest that you may be dealing with bradykinesia, of, uh, which is the primary clinical feature for Parkinson disease, right? And then, of course, they would drag their legs. They might have the feeling of shuffling and feeling unsteady, and so on and so forth, right? Uh, so patients generally don't come and say, no, I feel very slow. They will always have these set of clinical symptoms, and you need to look out for the fact that this might be actually clinical features of bradykinesia. It's the same for rigidity. So rigidity again is a core feature for the diagnosis of Parkinson or Parkinsonism. And one of the examples for rigidity is cogwheel rigidity and lead pipe rigidity, right? So can someone tell me what the difference is, the difference between rigidity and spasticity? Does anyone know? Does anyone know the difference? What do you mean by rigidity? What do we mean by spasticity? It's a very important point that I'm trying to highlight. What's the difference? Rigidity versus spasticity. Are these both increasing tone?
Upper motor neuron lesions cause spasticity.
Yes, versus rigidity, which is a feature of
Low motor.
low motor. Neurology has changed over the last 15 years, I suppose. No,
So in spasticity, the resistance occurs throughout the movement.
that's right.
In rigidity, it's not like it is initial resistance.
No, it's other way around. It's other way around. So rigidity, you see so both rigidity and spasticity, there's increase in tone. right? So there is increased tone. So your muscles, there is increase in tone around the joints, right? Muscles around the joints. Now, what is the difference between rigidity versus spasticity? Rigidity, you will see that the tone is increased uniformly, right? And it is throughout the range of movement, right? And what was it? It is also velocity independent. So how quickly you say if it's the elbow joint, how quickly you flex or extend the joint has no bearing on the tone. Basically, the tone will be independent of that of velocity as well as the range of movement. However, spasticity is where it is velocity dependent. So how quickly or how slowly you do it, and how you perceive tone, right? It depends on how quickly you do it, and also it is generally seen in the initial part of the movement, right? So which is called clasp knife rigidity, right? Clasp knife. It's like a clasp knife, right? So why is it important to differentiate the two, right? So rigidity is actually a physical sign of an extrapyramidal, the involvement of the extrapyramidal system, whereas spasticity is actually involvement of the pyramidal system. So it's important for us to differentiate the two, because we then are able to differentiate whether we are dealing with a pyramidal or extrapyramidal pathology, right? So I hope that's clear. And what do we mean by cogwheel rigidity is when there is rigidity and superimposed tremor on top of the rigidity. So then there is this ratchet-like pattern, right, of where we feel cogwheel rigidity around the wrist joint. That is the most common physical sign that you would look for in a patient, especially when the patient's got idiopathic Parkinson disease. Right. Hope that's clear, right? So, but now again, rigidity. Now, if a person is very rigid, they will not come and say, "I am rigid." What they will say is that they have that there is pain and stiffness, right, in their limbs, right? So, pain is one of the common symptoms of rigidity, so which you might have to look out for, right? So the symptoms of both bradykinesia and rigidity are different, and you might have to look out for those symptoms which might suggest that you might be dealing with a Parkinson related disorder, right? Now, when we talk about idiopathic Parkinson disease, which is the most common type of Parkinson disease, which I've described with regards to the pathology and the pathophysiology, the typical clinical features for Parkinson disease, which was described over 100 years ago by James Parkinson as a shaking palsy, is that it's typically starts on one side, right, and then spreads to the other side, right, and it remains asymmetric throughout the course of the disease. So which means, so for example, if it starts on the right and then spreads on to the left, the right is and the right will often be more affected than the left throughout the course of the disease, though you will see bilateral physical signs of extrapyramidal involvement, right? So that is very typical for an idiopathic Parkinson disease. Is it important for us to differentiate idiopathic Parkinson disease from other types of Parkinson's? Why is that important?
Because the pharmacological management will be differ from idiopathic Parkinson and secondary.
Yeah, absolutely. So basically it's the prognosis of Parkinson and Parkinson related diseases depends on your diagnosis. So idiopathic Parkinson disease by definition will respond to treatment, right? I will talk about treatment in a little while. Whereas the other types of Parkinson's disease, the response is generally variable, and sometimes there is lack of response. Okay. So that's why it's important for us to, right. Okay. So when it comes to idiopathic Parkinson's disease, there are also some symptoms which are not related to motor symptoms, right? So for now, what we have been talking about, like the examples of bradykinesia, tremor, rigidity, are all motor features of idiopathic Parkinson's disease. There are also clinical features which are called non-motor features, and some of the examples are on this slide. One is that they might come with cognitive clinical features, right? Where there is decline in cognition, so dementia or mild cognitive impairment. However, if someone presents with dementia early on from the onset of motor symptoms, then you need to be aware that you might not be dealing with a idiopathic Parkinson disease. You might be dealing with an atypical Parkinson or something like a Lewy body dementia, where, as I said before, right, where the proteins, like the example would be alpha-synuclein, has started depositing in the cortex, right, rather than in the basal ganglia. Right, it's important for us to differentiate the two because, again, prognosis and treatment might be different. Then, of course, there can be neuropsychiatric manifestations of Parkinson's and idiopathic Parkinson's disease. For example, depression, very common. Anxiety and depression are very common neuropsychiatric manifestations, right? And as well as hallucinations, which is a later manifestation of Parkinson's disease, right? And these neuropsychiatric or non-motor symptoms can actually precede the motor symptoms by many years. So sometimes these patients who are treated with antidepressants for years, then later on develop these motor symptoms of Parkinson's. And they are sometimes erroneously diagnosed as drug-related Parkinson's. They're actually not drug-related Parkinson's. Actually, these patients had depression as a non-motor manifestation of the actual Parkinson's disease, and later on presents with Parkinson's. It's a very common presentation where these patients have depression a few years before, and they are put on antidepressants, and then one fine day they have all these movements and movement, that are suggestive of Parkinson's or Parkinson's disease, and then thought to be due to the drug that the patient is prescribed. Right? And of course, autonomic manifestations like orthostatic hypertension, constipation. So the autonomic dysfunction is quite common, but again, a late manifestation, especially when it comes to idiopathic Parkinson's. Sleep disorders, REM sleep behavior disorder is very characteristically seen in a group of movement disorders that are a result of the deposition of alpha-synuclein. So synucleinopathies. So if the pathology involves abnormal protein deposition and the protein is alpha-synuclein, right? The neurodegenerative group of disorders are called alpha-synucleinopathies, right? Of which an example is Parkinson or idiopathic Parkinson's disease. Now, in this group of neurodegenerative disorders, REM sleep behavior disorders are very common, and they sometimes occur many years prior to prior to the motor manifestations of Parkinson's disease. So, does anyone know what REM sleep behavior disorder means? what is this REM sleep behavior disorder? This is out of interest, so you don't really need to know it, but what is this REM sleep behavior disorder? Does anyone know? Yes? No? Right. Okay. So I hope everyone knows that the sleep is divided into REM and non-REM, rapid eye movement sleep and non-rapid eye movement sleep. Right. Okay. During REM sleep, does anyone know that that there is complete atonia? Sorry. Yes. There's an answer. People act according to dreams in REM. Yes. So that's what they do. Yes. So during REM, right, below our neck, we are completely paralyzed, right, apart from the diaphragm, right? So, so there is what that's called REM atonia. So that's what we look for when we do a polysomnography, right? And we try to categorize the stages of sleep during a polysomnography. I hope everyone knows what that means. And when we categorize that, there is complete atonia, where the muscles are completely paralyzed apart from the diaphragm. If the diaphragm is also paralyzed, obviously we'll stop breathing. So that doesn't happen, right? So that's a phenomenon that we see with REM sleep, right? So, but in these patients, right, that REM atonia is lost, right? So during they often see vivid dreams, often nightmares, right? Often these are violent dreams, and they seem to be basically acting out their dreams. Often they are seen punching, fighting, that kind of thing, especially during the night, during REM sleep, right? So these are called REM sleep behavior disorders, which is not normal, right, and can affect and fragment sleep, and it is classified as a sleep disorder. Now, what's interesting is that, right, that there was a study that was done where these patients with REM sleep behavior disorder, where they didn't have anything, idiopathic REM sleep behavior disorder, there was no evidence of any neurodegenerative disorder for these patients. And these patients were then followed up over years, right? To see what really happened to these patients. And as time went on, right, and these patients are followed up, more and more patients with just REM sleep behavior disorder started developing motor symptoms of Parkinson and Parkinson-related disorders, right? So at the end of 15 years, nearly 100% of that cohort of patients which are followed up for a long period of time developed some sort of neurodegenerative disorder, which was grouped as an alpha-synuclein or synucleinopathy, and of which there's a large proportion of patients who are having Parkinson disease, right? So REM, so the message here is that these non-motor manifestations of Parkinson disease can precede the motor symptoms by many years. Right. Right. So what should clinicians ask patients when evaluating them for Parkinson disease? Of course, as I said, tremor at rest, bradykinesia, stiffness, they are all features of Parkinson disease. Of course, the motor manifestations can affect other aspects of the lives of these patients. So, for example, the speech can be affected. Bradykinesia can affect speech, which manifests as hypophonia, right? And there is decreased volume of speech. You can barely hear them, right? So that's hypophonia, right? Micrographia means smaller handwriting, right? So the handwriting becomes small because of the rigidity as well as the bradykinesia affecting the distal parts of the limbs. Then, of course, drooling and excessive salivation, again, because of autonomic dysfunction, as well as dysphagia, which is quite commonly seen in patients with Parkinson's disease. Difficulty turning over in bed, it's very common symptom, especially at night, right, where the rigidity is, affects the patient, and often this wakes them up. That is one reason why they might have daytime hypersomnolence, because they have a very unrestful sleep at night, right? So changes in posture, as someone suggested, where the axial muscles or the muscles around the spine are affected due to rigidity, and they appear to stoop, right? And there'll be a change in gait, which is called a festinant gait. Constipation, a very common non-motor manifestation of Parkinson's disease. Again, constipation can precede the motor symptoms by many years, right? And it's a very difficult symptom to treat as well. Anxiety, depression, we talked about. Olfactory dysfunction, again, common because there can be deposition of alpha-synuclein along the olfactory bulb, as well as the otorhinal cortex, right? And therefore, they have this olfactory dysfunction. So their sense of smell is affected, and sometimes even in neurologic clinics, sometimes we use that to try to differentiate whether this is an idiopathic Parkinson's disease by using a sniff test, where we tell this patient to try and smell very familiar fragrances to see if they are able to pick them out and differentiate, right? And of course, exposure to drugs that can cause Parkinson's or Parkinsonism is a must when you actually take a history and family history. There is a global sort of research over 60 countries, in which Sri Lanka is also a participant, where we are trying very hard to describe the genetic forms of Parkinson's disease. So there's a huge interest in trying to delineate the genetic sort of inheritance of Parkinson's disease, because there are certain types of Parkinson's disease which are inherited, where there is a strong family history. So when you are actually asking, or when you are evaluating a patient, it's important for you to ask for a family history as well, right? So neurological examination, someone had suggested that these patients will have a masked faces, yes, right? And that manifests as decreased eye blinks, right, and diminish expression, right? So that's very common, where bradykinesia affects the muscles of facial expression, right? Then tremor, right? How do you check for tremor? You need to tell the patient while they're seated, to keep the hands on their knees and to relax. And sometimes mental tasks like calculation or counting backwards, I often tell my patients to count backwards from 2019, so on and so forth. So as they count backwards, their focus is elsewhere. Then you start seeing the tremor, which is generally prominently seen at rest. So the patient needs to be nice and relaxed, right? And sometimes movement of the opposite limb also brings about this type of tremor, bradykinesia. So when you are examining these patients, how does one demonstrate bradykinesia? It's by doing these rapid and repetitive movements, right? And then so what I do is I generally tell the patients to tap their index finger and their thumb, right, and tap. And what do we observe? We observe a decrease in both amplitude and frequency, right? So there is a reduction in the rate in which they tap, the N, the amplitude, and this is called fatiguing, or the movement fatigues over time, right? Why is it important for us to notice both the reduction in amplitude and frequency? Because this is also seen in patients with upper motor neuronal lesions as well, right? But there, the slowness is uniform, right? You don't see this fatiguing effect, like you would see in patients with bradykinesia, right? And of course, the movement is less coordinated as the Parkinson disease progresses. Rigidity is you need to manipulate the limbs passively and check their range of movement around the joint and see if look for increase in tone. Right. Some videos of our own patients. Okay. So can someone comment on what was seen on the video? I hope the video was seen. Was it visible? I hope.
Yes, it was visible.
Yeah. So can the participants comment on what was observed? Yeah. What were the physical signs that were seen?
Involuntary tongue movements.
Sorry.
The tongue, continuous tongue movements, involuntary.
Yeah, tongue movements. What was it that you saw? What were the tongue movements? What do you think it was?
Fasciculation.
Okay. I thought it was, so this is a movement, no? Tongue was moving, no?
Yeah.
What do you think it was? Was it rhythmic or arrhythmic? Was it going to a rhythm where there was uh, a consistent frequency, or was it arrhythmic?
Can you replay it, Kishara, while they're answering so that, yeah.
Yeah. So I hope that was clear, no? Yeah. So there are several physical signs that you see in this patient. What did you see?
Mask-like face.
Yes, right. So the face, there's very little expression that you see on the face. So that is one. Yes. So that is called hypomimia that we are seeing in this patient. What else? Yes. TD. Someone has thought that this is tardive dyskinesia. What else? Yeah. So there were, mask-like faces. Yes. Someone had said no eye blinking. Yes. So all that. So there's hypomimia. So there's bradykinesia affecting the face. What else did you notice? Yes. Anyone? So this is exactly what you need to pick out. That's so I'm
With
showing you.
moments, tremor
Tingling.
settles.
Sorry?
With moments, tremor settles. The
With
intention.
movements?
There's
Yeah.
no obvious
So,
tremor.
so there is so yes, someone said tremor, right? So where is the tremor? Where is the tremor? Where do you see the tremor?
Tongue.
Tongue, absolutely. Yes. So that's the tremor of the tongue, right? So just remember that the tremor that you see might not be seen in your hands, right? So tremor might be seen elsewhere. So this is one example where the tremor is actually seen in the tongue, right? So tremor at rest, right? He's not speaking, no, he's just opening his mouth and waiting. Right? So it's tremor at rest. So tremor at rest involving the tongue. So any body part which is the distal part of the body, and you see features of tremor at rest, it is Parkinson or Parkinson related disorder until proven otherwise, right? So that is one. So you see hypomimia, you see tremor at rest, but not in the hands, but in the tongue. What else for? So you see the patient is also doing alternating movements. No, he's tapping. What did you notice in this in the tapping that you see? One thing is he was instructed to do it as quickly as possible, right? Right?
Slowness.
Yeah.
Slowness.
You see? What are you seeing? What happened to the amplitude on the left? What happened? Amplitude, the movements, they were large movements before, no? And then as time progressed, what happened to the movement? It became smaller, isn't it? So the amplitude reduced over time. And then of course there is obvious bradykinesia in the sense the frequency is very low, right? Apart from his bad teeth, right? Which is another problem. He has features of bradykinesia, that is demonstrated by the finger tapping as well as the hypomimia. And of course, he has a tremor at rest, but not seen in the parts that you would expect to. But this is also quite common. The tongue involvement is also quite common. Okay, so that's a right. So same thing here. Right. Okay. Now what do you see? So what are you seeing now? Yeah.
Tremor of the jaw.
Tremor of the jaw. Okay. What did you notice there? What did you notice?
No
Right.
blinking of eyes.
Yeah. Right. So there's tremor elsewhere as well. Can you see that here? The
Leg.
legs are, yeah,
Leg.
the legs are also, there's tremulous, right? And then what happens now? Just see what happens. Now so what happened to the tremor now? Did you see that? Yeah? What did you notice? What did you notice?
She spoke, so it reduced.
Exactly. Absolutely. And that is what is very typical of Parkinson's, right? Where when on action or when the patient is told to do something, the tremor nearly disappears, right? And then re-emerges later on, right? And that is what's called a re-emergent tremor, right? And that is very typical of Parkinson's, right? So when a person is told to when he has tremor involved in the hands and he is told to outstretch his hands or stretch out his hands, right? The tremor disappears for a little while and then reappears. So that is very typical of Parkinson disease, right? So that's called a re-emergent tremor. So what are physical signs in this patient? One is the hypomimia, as someone suggested. She's got tremor all over the place, the jaw, the hands, the feet, right? And what happens when on action, the tremor disappears. So that's called a re-emergent tremor, right? I hope that's clear, right? Okay, so another video, interesting one, right? Right, so here again, as I said before, if you see a tremor, which is prominently seen at rest, this is the typical pill rolling tremor. Now, do you think this patient's got idiopathic Parkinson disease or not? Or does he have any another form of Parkinson's disease. So what do you notice there? What did you notice?
No hand movement. He's walking.
Is what was that again?
Asymmetry.
Absolutely. This video, the example here is not the tremor, but the fact that it is asymmetric. So you can see that his right side was more affected than the left side, and the arm swing on the right was much less compared to that of the left. And remember, unlike other causes of tremor, tremor in Parkinson's disease is worse when you're told to walk, right? So when you walk, right, other forms of tremor actually reduces, whereas in Parkinson's disease it is accentuated, right? So this is another clinical test that we would do to assess, especially tremor, right? This is something called the Archimedes spiral, right? Where patients are told to trace this sort of world, right? And in Parkinson's disease, you can see, right? It's smaller than the actual Archimedes spiral. So you will see micrographia when they trace this Archimedes spiral. More importantly, one of the main differential diagnoses and often referred to a neurologist because of the suspect when primary physicians suspect Parkinson's disease is the fact that these patients have tremor, and when they see tremor, often the differential diagnosis, one of the main differential diagnoses is that this could be essential tremor, right? So completely different entity altogether, and treatment is completely different. So one way of differentiating between essential tremor and Parkinson's disease is the fact that when they the difference that you see on this slide, right? You see these wavy lines; they're hardly able to trace this Archimedes spiral if they have essential tremor, because action makes the tremor worse in essential tremor, which is contrasting in Parkinson's disease, where the actions don't make the tremor worse. Of course, as Parkinson's disease progresses, sometimes even for the clinician who is experienced, sometimes it might be difficult to differentiate the two. Right. Okay. Hope all that is clear. Yeah. Okay. We move on now. So how do neurologists establish the disease, the diagnosis of Parkinson's disease? So Parkinson's disease or idiopathic Parkinson's disease is a clinical diagnosis. There is no test that is done, at least in Sri Lanka or even in most parts of the Western world, where we would run tests. There are, of course, now tests that are being developed to see whether we can confirm the diagnosis of Parkinson's disease. But essentially, for clinical practice, the diagnosis is a clinical diagnosis, right? And you need to have bradykinesia as its co-clinical feature, plus tremor or rigidity should be present for you to label this patient as a patient with Parkinsonism, right? And if it is asymmetric, right, and if there is sustained clinical improvement on levodopa, which is the main form of treatment of Parkinson's disease, then you can make a diagnosis of idiopathic Parkinson's disease. Now, you need to rule out signs of alternative of an alternative diagnosis. There are several features, or there are several Parkinson mimics, as well as disorders which look like Parkinson disease but isn't, right? And it's important in your clinical, evaluation to differentiate. And this is a list of things that you would look for. which might suggest an alternative diagnosis. And I'm not going, I don't, due to the due to time constraints, I don't think I have time to go through that list, right? So, are there any investigations that we would run as neurologists, right? We would generally do brain imaging if there is a doubt in the diagnosis of Parkinson's disease, or if the patient has Parkinsonism with an alternative pathology, right? So that is one reason why we would do a brain scan, an MRI, of course, PET and SPECT. Again, if the diagnosis is that of, whether if there is an alternative diagnosis. Remember, if a patient comes with features of Parkinsonism, that is bradykinesia or tremor or rigidity, at a younger age or age less 40 and less, then as clinicians, we are bound to look for a treatable cause for Parkinson's disease, of which Wilson disease is one of the though less common, but one of the treatable causes of Parkinson's. So we would generally screen for Wilson disease if they present at a younger age. How do we manage these patients, right? There's both non-pharmacological as well as pharmacological therapy. Why have I put this non-pharmacological approach first? Does anyone know? Yeah? Why non-pharmacological approach first?
It's easy.
It's easy. My God. Is
The
it?
patient education per se.
Sorry?
Patient education per se can help him understand that pharmacological therapy will not cure the disease and.
Okay.
Pharmacological therapy will stop being effective at some point.
Okay.
You
Right. No.
start
So
treatment early, you can get side effects.
why I have put this first is because it is as important as that of pharmacological therapy, right? Because people
psychologically will be strong patient.
Yeah. So the answer is that it is as important as pharmacological treatment. We as clinicians also always forget the physical aspect of with the physical rehabilitation of Parkinson and Parkinson-related disorder, which is very important because exercise itself can have can improve the quality of life of these patients, and it has been proven over and over again through several descriptive research, several studies that exercise has a positive effect on the quality of life as well as the has a positive effect on the motor manifestation as well as the non-motor manifestations of Parkinson's. So don't forget non-pharmacological treatment for patients with Parkinson's. Of course, the pharmacological treatment, levodopa, carbidopa, is the gold standard, and that is what we look for. The response to levodopa, carbidopa is the main feature that we look for when it comes to prognostication as well as making a diagnosis of idiopathic Parkinson's disease. Then, of course, there are other forms of medication, pharmacological medication, where we that increases dopamine within the central nervous system, dopamine agonists such as pramipexole and ropinirole, as well as MAO-B inhibitors such as seligelin and COMT inhibitors such as entacapone and are all useful in the pharmacological treatment of Parkinson's disease. And of course, there are advanced therapies which are not available in Sri Lanka, especially when, as time progresses, Parkinson's disease becomes more and more of a challenge to treat, especially because of complications of bioavailability of levodopa, fluctuations within the serum and the blood basically causes a lot of problems such as peak dose dyskinesia, wearing off effects, which mean as time progresses, they become less sensitive to levodopa. So there are lots of problems, and in those cases where the Parkinson disease is advanced, then there are advanced therapies that can be utilized. Not so much available in this country, simply because these forms of treatment are very expensive, and however, there are, I think, efforts to try and establish these kind of advanced therapies in Sri Lanka as well. So one is deep brain stimulation. There are other forms of treatment such as duodopa, where we infuse continuous infusion of dopamine into the jejunum. Then there is something called pro-duodopa, where there is continuous infusion of levodopa into the blood itself. So these are all advanced therapies, not so much available in treatment. Now, a little bit about hyperkinetic disorders, right? Normally, so hyperkinetic disorders, as I said, due to excess of movements. So they can be again. So when you describe or when you observe these hyperkinetic disorders, it's important to look for whether these are rhythmic versus arrhythmic, right? Whether these are sustained movements or non-sustained movements, or whether they are continuous or paroxysmal. Because if you categorize it according to on how you observe, then it's easy to make a diagnosis based on the phenomenology, right? So this is a classification based on the phenomenology. So you can see if it is rhythmic, then you're most likely dealing with a tremor. Non-rhythmic and sustained, you're dealing with a dystonia. If the non-rhythmic movements are slow, you're most likely having, or the patient is most likely having athetosis. If it is non-rhythmic fast, right, and it is suppressible, then it's a tic disorder. If it is not suppressible, then you have this 4 or 5 differential diagnosis that is at the bottom of your screen. Now, a little bit about tremor, right? What do we mean by tremor? It is an involuntary, rhythmic, oscillatory movement of a body part. Okay, and I just want to. So you need to look at few things, right? Of which activation conditions. When is the tremor worse, right? Is it at rest, posture, right? Certain postures, or whether during action, kinetic. So if your tremor is worse at rest, right? What is the diagnosis?
Parkinson.
Parkinson's.
That's right, Parkinson. If the tremor is worse at sustained posture,
Essential tremor.
that is essential tremor. And if it is kinetic, more likely that you're dealing with a cerebellar tremor. It's not as simple as that because there's considerable overlap, right? So rest tremor we've already spoken of, right? Related to Parkinson's disease. So tremor during sustained posture, it's generally you're dealing with a condition called essential tremor, right? So these are the diagnostic criteria of essential tremor. It has to be an isolated tremor syndrome involving the bilateral upper limbs, right? And it has to be there for at least 3 years, right? Or without tremor in other locations. There can be tremor of the head, voice, or lower limbs, but your upper limbs have to be involved, right? And there should not be other movement disorders that will give a alternative diagnosis, such as dystonia, ataxia, or features of Parkinsonism, right? Now, so just to show you the difference, or at least try to show you the difference between Parkinson tremor and essential tremor. Right. So what were the features that you observed in this video? Hello? Yeah? What was it that you saw? What was different?
In resting, there is no tremor.
That's
With
right.
movements, there is tremor. The
Yeah.
Archimedes spiral also looks
Yeah.
not like not micrographia. It's like essential tremor.
Yeah. Actually, there was a slight tremor, if you notice, on at rest, right? So did you see that there is a slight tremor? Yes. But now, when the patient is told to stretch his hands out, the tremor is really accentuated, right? And when he is doing various tasks, right, the tremor is worse, right? So it's kinetic tremor. So, but what is worse is when the patient is having, keeping the hands in a sustained posture. And of course, you can see that the Archimedes spiral, he can barely trace the Archimedes spiral. So these are all components of an essential tremor. Now, the difference between Parkinson tremor and this is that tremor is worse at rest in Parkinson's, whereas here it's worse during sustained posture and sometimes kinesis or during action. And it barely can trace the Archimedes spiral. So I hope you can now differentiate the two types of tremor, right? So not all tremors are Parkinson's disease, right? So it's important to differentiate the two. So what's dystonia, right? Generally, a dystonia is characterized by sustained and intermittent muscle contraction that causes abnormal and often repetitive movement and posture. So these are abnormal postures, right? And they're typically patterned twisting, and there can be a tremor superimposed on this movement, right? So just to show you what a dystonia looks like, right? So this is a patient with a cervical dystonia. So you can see, right, that the patient, this is he barely can look over his shoulder because of his where the agonist and antagonist muscles are both contracting, right? But what you see now is that when the patient is asked to touch his head, he's able to go back to his normal posture, and that's a phenomenon called guest antagonists, right? Or what's called a sensory trick, right? That's very commonly seen with these cervical dystonias, right? So this is an example of sustained contraction of the muscles, right, which causes an abnormal posturing, right? And it is not a fixed posture, mind you, right? If it is a fixed posture, then it is something else. It's not a movement disorder. So, but generally the movement is sustained. So this is an example for a sustained movement disorder, which is arrhythmic, right? So we spoke a bit about sustained one, non-rhythmic movement disorders. This is again a non-rhythmic athetosis, chorea, and Ballism are examples of a non-rhythmic movement disorder, right? And so this is amplitude. So as we go from left to right, the amplitude of this movement disorders gets worse over, right? So Ballism, you will have large amplitude, violent movements, right? Whereas athetosis, you will have slow, low amplitude movements. So as the arrow goes to the right, the frequency and the amplitude increases. Right, so chorea means dance. So these are irregular, unpredictable, brief, fidgety movements that are usually of low amplitude, right? And they flow from one part to the other and generally semi-purposeful. They can be categorized according to which part of the body is affected. So it can, if it is all the parts, it's generalized. If it is segment that is involved, or it can be localized. So this is an example for a coriform movement disorder. So you can see, right, this patient is fidgety, right, and he barely can stay still, and this is called motor impersistence, right? And you see that these movements are fairly semi-purposeful. When the movement occurs, he tries to cover it up by trying to sort of use natural movements.
It can be the movement of the chest involuntarily.
So this is an example for coliform movements or hyperkinetic ones, right? So this is different to that of myoclonus, right? So myoclonus are very short-lasting movements. They are brief shock-like movements, right? That can be a result of um, dysfunction of the brain. It can be some problem in the cortex, subcortical region, or even lower down in the brainstem or in the spinal cord. I just want to show you what a myoclonus looks like. Did you notice that? Did you notice that the brief shock-like movement? There, you saw that very brief shock-like movements of the hands, right? So this is an example for a myoclonus, which is a non-rhythmic, brief, shock-like movement involving the upper limbs. It can involve any part of the body, but what you saw was the upper limbs. Then, of course, tics, right? You might encounter as primary physicians a lot of children coming. This is very commonly seen in children, where there is intermittent repetitive stereotype movements. Either it could be motor or vocal, right? These are tics, right? And generally these movements are preceded by an uncomfortable feeling or what's called a sensory urge. And once the movement occurs, there's relief for that particular patient, right? So he's relieved. So he's able to. So how would you differentiate these movements? Is you tell the patient to try as much as possible to sustain it voluntarily. He or she is able to do that. But as soon as you tell them to stop, then there is a overshoot of. You will see an increased frequency of these movements just after they stop the voluntary suppression, right? And that is very typical of a tic disorder. They are again generally divided into simple versus complex. So this is an example of a tic, right? So you can see he's making some sounds as well. So he's got both motor as well as vocal tics, right? So this is an example for of a complex motor tic disorder. And as the video goes along, he's instructed to Okay. So what did you notice there? Did you notice anything there?
The movement of the chest.
Sorry?
Movement of the chest vocal.
No, but when he was asked the various questions, what happened to the movement?
It's the involuntary movement of the chest.
Yeah. Was it
Movements
involuntary or voluntary?
reduced.
What happened?
Reduced.
Yeah, it reduced, no? So distraction made the movement better, right? And later on, I'm not sure whether they tell to suppress, right? You can tell the patient to, okay, try to stop the movement, and they are able to do that for a brief, right? Right. So then after that, there is a rebound phenomenon where there is an increase in the frequency of movement. So this is very typical for a tick. So I've gone through a lot of movements today, hyperkinetic as well as hypokinetic. Very important for you to try and describe the phenomenology of the movement, especially when it comes to hyperkinetic disorders, and try to classify it into rhythmic, non-rhythmic, sustained, slow, and fast, right? So basically, come to the end of this talk. So always try to describe the phenomenology of the movement first, right? Remember Parkinson, now it's called Parkinson disease, not Parkinson's disease. Is the most common movement disorder in older adults. It's very important for you to identify this movement disorder early in the course of the disease. Early recognition and treatment significantly improves quality of life of these patients, and primary care physicians play a vital role in recognizing, especially Parkinson disease in its early stages, and which allows referral for the appropriate treatment. So I thank you for your attention. If there are any questions, I'm happy to answer.
Thank you, Kishara, for that excellent presentation. It's really very descriptive and informative as well. So there's one question. Does caffeine contribute to the hyperkinetic movement disorder?
Caffeine can make tremor worse, if that's what you're asking.
No, contributes to the hyperkinetic movement disorder. I don't know whether it's causing or excessive caffeine.
So yeah, it's not a etiology, but it can make the hyperkinetic movement disorders worse.
And I think this is related to the video that we saw.
Yeah.
There is that in Parkinson's disease, while walking, the tremor increases.
Yeah. So that is one way in which we differentiate. So the main differential diagnosis of Parkinson tremor is essential tremor, and often we even the experienced neurologists sometimes find it difficult to differentiate the two, because there's another entity called essential tremor plus, where you have mild features of bradykinesia on top of the tremor. So that can sometimes give an idea whether you're dealing with Parkinson related tremor, Parkinson disease related tremor, or essential tremor. So one way of differentiating the two is to actually make the patient walk. And if the tremor that you see at rest is actually worse while the patient walks, right, you are more likely dealing with a patient with Parkinson disease than that of essential tremor, where essential tremor actually gets better when the patient walks. I hope that answers that question.
And there's another question. Can we start treatment at GP level or should we refer?
I think initial diagnosis should be at the level of specialist, because there are so many Parkinson mimics as well. Sorry?
Like to Parkinson. So you have to differentiate. That's
Yeah,
very important.
absolutely. Because that also, there are so many other differential diagnoses. I did not touch upon atypical Parkinson and, because the
Other
Parkinsonism can be due to another pathology where there is another protein called tau, and those neurodegenerative disorders are called tauopathies. So where they are the levodopa and everything, that we generally know of that treats Parkinson disease is ineffective. So I think the initial diagnosis should be made at the level of the specialist. Of course, follow up and I think it's important that follow up is at the primary level, primary care level. So I think initial evaluation should be at the level of the specialist because of the fact that it's a huge spectrum of disorders that can mimic Parkinson.
There's another question. Sudden feeling of falling to one side within a second and return to normal can be due to what movement disorder?
Not sure. Generally, that sounds like a vestibulopathy rather than a movement disorder. There is something called, as Parkinson progresses or any neurodegenerative disorder that progresses, their rooting reflex is lost, which means they are unable to maintain balance in cases where they are, they lose balance. For example, that is one test that we look out for postural instability, where we pull the patient. So we go behind the patient. We explain to the patient that we are going to pull them towards the examiner, and that's called the pull test, right? And when we do that, the patient with absent rooting reflex will not be able to maintain balance, and they will fall towards the examiner, or they will take a few more steps to stabilize themselves and prevent themselves from falling backwards, right? So that is postural instability, which is seen in Parkinson disease as well as atypical Parkinson disease. But in Parkinson disease, that is a late manifestation, whereas when it's an atypical Parkinson disease or Parkinson syndrome, that we see very early. I think that is probably what that particular person is asking. Of course, for a few seconds and back, generally might be a completely different pathology altogether. Often we see that with, especially with head movements and loss of balance is generally seen in patients with vestibulopathy.
Quick reminder for participants, please fill the Google form for your CPD certificates. And there's another question. If levodopa fails, what next?
So if levodopa fails, that we'll have to think of an alternate diagnosis. What we generally do is, if levodopa we don't, if the patients, we think that this patient's got idiopathic Parkinson. We start them on levodopa. Patient comes back for a follow-up, right? Patient says, no, there is not much of an improvement, right? What I do in my clinical practice is that I would generally, not very few, I'm one of the few neurologists who does it. I would do what's called levodopa challenge test, right? There is a very objective rating scale called the UPDRS. Just Google it, right? So it's a rating scale and there is a motor component for the rating scale. You would tot it up, assess the patient, tot the score that the patient gets. Then give them a larger than normal dose, that say approximately 125% of the dose of levodopa that one would get, and then reassess in when the patient either feels better or in approximately 2 hours, to see if there is a difference in the score and there is an improvement in the score. If there is an improvement of more than 33%, that means that the patient is levodopa responsive, which means that the drug is working, and which means that your diagnosis of this patient is more likely to be idiopathic Parkinson's disease. And therefore, that is one reason why this patient should be on levodopa. Okay, but if the patient does not respond and there is a less than adequate response, then more likely that you're dealing with something else and not idiopathic Parkinson's. So then you need to review the diagnosis. I hope that answers the question. And that is why evaluation should be done at the specialist level.
What are the side effects of Parkinson's that should be Parkinson's drugs that should be monitored in primary care, and how often?
Yeah. So levodopa, very common, is nausea and vomiting. As we start off the medication, we generally tell patient, because it's very irritative, we tell the patient to maybe have it with meals, maybe give an antiemetic as we start off. Or generally what I do is I give them a very, very small dose to start off with, and then slowly increase it to the therapeutic dose. So that is very, very, very common. Nausea, vomiting, very common. And sometimes I even change the levodopa to a control release levodopa to reduce that uncomfortable GI side effects. So that is with levodopa, right? So then with dopamine agonists, something that the patients generally don't come out with this something called impulse control disorder, where the patients are unable to control their impulses. And they don't come out with that. They sometimes, when the patient is on dopamine agonist, they go out on, buying sprees. They start buying, it's just like bipolar affective disorder, where they start, buying very expensive things, which generally they can't resist. Then they become hypersexual as well sometimes. So these are symptoms and symptoms which the patient themselves don't come out with. It's very important to actually interview the relatives or the carers when these patients come to you, because that is something that they might not come up with. So that is a red flag where you might have to reconsider the dopamine agonist. So those are the two main things that I would like to highlight, especially that things which you need to monitor. The other thing is some of these medications can cause severe postural hypotension, especially when the autonomic dysfunction starts happening as the disease progresses. So it's important for you to check for postural drop in the blood pressure.
There's another question. Can nystagmus be seen in Parkinson's disease?
Sorry, what are that? Nystagmus?
Nystagmus, yeah.
So nystagmus is a feature of cerebellar involvement. So generally we don't see nystagmus with idiopathic Parkinson disease. We might see it, especially if it is associated, when the Parkinsonism is associated with cerebellar syndrome, and there is alpha-synucleinopathy called multi-system atrophy, where there is prominent cerebellar signs. There we might actually see some nystagmus. There again, it's not very common, but not particularly for Parkinson disease, which is idiopathic.
There's a question. Can you please elaborate more on the follow-up at primary care? I think maybe we can try and do another session probably on Parkinson's and management.
Yeah.
More
So this was
elaborate.
movement disorder.
Yes.
Yeah. So it's a broad
Yeah.
topic.
Yes.
I went through the evaluation part of it.
Now, yeah.
Yeah, and detection.
But probably
That's
it's something
another
very
topic
important,
altogether.
Kishara. We see quite significant numbers coming. I don't know whether it's actually increasing or whether people are being more aware and coming for treatment. So I think it's something we should really
then the
focus
topic
and
should
highlight.
change. Then it's
Yeah.
Parkinson's
So we
disease
will
follow-up.
do maybe next in the future.
Yeah.
Management of Parkinson's and follow-up and whatever is primary.
Yeah. Absolutely.
Should we check any particular blood test during follow-ups?
Not particularly. I don't think I check for anything apart from the fact that sometimes infection and certain other comorbidities, or especially when you're in the old age group, geriatric age group, any movement disorder can be worse during infection. So if there is an infection, sometimes the movement disorder gets worse. So that is, so if it does really get worse, then there's, you need to check out whether, commonly it's a urinary tract infection. You need to screen for some sort of infection, but there's nothing that I would generally do when it comes to routine blood tests.
Yeah. I think because of the interest of time, we might have to stop. It's 10 past 10.
Yes, sorry about
Yeah.
that.
No, that's okay. It was really interesting, and I mean, these are the questions that have come from the participants. That means they have really sort of engaged and listened very enthusiastically. Thank you very much, Kishara, once again for joining with us, and thank you, Priyantha, for organizing this wonderful session. So, hope to see you all with the next month's CPD session. So now we have started a Facebook page with the request actually from the participants in this group. So we will post our sessions in the Facebook page as well. So please do follow the page so you will get the notices in the Facebook page as well. So we'll stop for now. Thank you everyone for participating and have a good night. Hope to see you next month.
Thank you.